It's my pleasure to introduce Dr. Naureen Starling, who's a consultant medical oncologist from the Royal Marsden in London. And she's going to be talking to us about liquid biopsies to improve the speed at which we make diagnosis for pancreatic and biliary tract cancer. Dr. Starling.
Thank you for the introduction, and thank you to Helen and team for inviting me back this year to provide an update on our Access Liquid Biopsy Innovation Project. So liquid biopsies in the diagnostic pathway to attempt to speed up the diagnosis of pancreatic and biliary tract cancers. So I think for this audience, pancreatic and biliary tract cancers need no introduction. They are cancers of unmet need. As Professor Khan explained, they often have a late presentation with advanced disease, and we definitely need advances in early detection. We have no national screening program. There's not one anywhere in the world, and that's much needed. That's not the focus of Access, although it is clearly a very, very important area. Tissue diagnosis in the diagnostic pathway is challenging. These tumours, biliary tract tumours, as you've heard, are located deep within the body, particularly hilar cholangiocarcinomas. They can often be difficult to get a good chunk of tumour tissue to make a diagnosis in order that the patient can then progress and access therapy. We know that maybe 1 in 5, 1 in 4 of these invasive biopsies are non-diagnostic, and then the patient has to go through that process again. And sometimes this can be very protracted. We've heard countless stories of patients stuck in this sort of diagnostic quandary, sometimes for months. And I think for many of us, many of you, it's no surprise that when it comes to NHS targets for the faster diagnostic standard, diagnosing within 28 days, or to treatment within 62 days, biliary tract and pancreatic cancer really fall foul of that standard, and we are not achieving it. And so there is a real impetus, I think, in terms of the diagnostic pathway to speed patients through this in order to access treatment. And that's very much the focus of our Access Innovation Programme, which is funded through an Innovation Award by NHS England and SBRI for faster earlier detection. That's not our focus, but clearly important, or faster diagnosis. That is our focus. So we're collaborating across 6 NHS trusts. This is all based in my region in London, in order to try and speed up diagnosis using liquid biopsies. I'll come to those, adding them to the diagnostic pathway for patients with suspected bile duct and pancreatic cancers, in order that we can reduce repeated biopsy rates, speed up the process, reduce the potential for complications like pancreatitis, improve the patient experience, and actually have a much more efficient NHS offer. And with a view to, if we can prove these things, having a blueprint for how to scale this across the NHS. So it's very much a pilot project. So many of you may be familiar, but if you're not, what is a liquid biopsy? Well, actually, cancers can secrete tiny bits of themselves, DNA, into the bloodstream. And we now have the technology with advances in something called next-generation sequencing, which you'll hear more about, to really detect that cancer signal. It is like finding a needle in the haystack, but actually we can now find that needle with some of the technologies. There are lots of different liquid biopsy being developed, but those that are validated for use in clinical practice today include the Guardant 360 and Foundation Medicine, where we can use that. Classically, we use those tests to do the molecular profile for the tumor, but here we're inverting the need and saying, well, yes, we want that, but we also, if we're detecting tumor DNA, can we not use that to support the fact the patient has a diagnosis of biliary tract cancer? Guardant 360, FDA approved, covers about 73 different genes. Many of these genes may be targets for which we have drugs. So I guess another gain from my perspective about doing this earlier is that we're going to need to do it anyway in bile duct cancer. Can we not just pull it up the pathway, make it work hard, make it help us make a diagnosis, but also get information for the patient, which may direct precision therapy? We know that ctDNA, so positive liquid biopsies, can be detected in up to 80 to 85% of advanced biliary tract cancer, and actually 80 to 85% of our patients present with advanced disease. There is a need for earlier stages 1 and 2. Tests are being developed. It's really encouraging to see the progress, but they're not yet validated for use in clinical practice. And I say that because you may wonder why we're focusing in this program on stage 3 and 4. So if I just sort of walk you through this, in terms of the current diagnostic pathway in blue, in our program, we are looking for patients with suspected biliary tract cancer or pancreatic cancer on imaging. If the imaging is highly suggestive, these patients will currently go through invasive diagnostic testing. You can see on the boxes on the left, this is a multi-step process which involves invasive diagnostics. Some patients struggle to get into this pathway because they are unwell or they've had a recent complication like pancreatitis. Some patients loop around this pathway in terms of getting inconclusive biopsies. And some patients get stuck in the pathway because, anyone of you who is process-minded, the more steps you have in a process, the more chance there is for delay. That's not always true. There are some good examples of how this works really well, but this contributes to diagnostic delay. What we have done within this innovation program is add a blood test into the diagnostic process. So when the patient has a scan highly suspicious of stage 3 or 4 pancreatic or biliary tract cancer, they are offered, in addition to the invasive testing, information about the liquid biopsy. And this turnaround time is a consistent 7 to 10 days. Currently, the test is sent off to the US, but for reasons I'll come to, we think this can be transitioned into the UK. So patients who are eligible within these 6 NHS trusts are aged 18 or above, have radiologically suspected stage 3 or 4 biliary tract or pancreatic cancer because the test is validated for that group, that's 80 to 85% of the patients, and a performance status suitable for oncological therapy. I actually kept that quite broad when we submitted the grant because I think actually some patients who aren't suitable for diagnostic treatment, the patient, their family still want a diagnosis, but we were asked to keep it to patients who are for treatment currently, but we'll come to how we might expand this, the indications. Exclusion includes patients who've had a cancer within 3 years because that can confound the liquid biopsy interpretation, but again, in the future, we may need to look at that. The liquid biopsy that we've used is Guardant 360, which is validated for stage 3 and 4. All tests will need to be interpreted by the molecular tumour board. Now, I knew there was a molecular tumour board. It was doing something in lung cancer in West London, but I didn't really understand its purpose until we did this program. We've managed to infiltrate it with all of our cases, and it is incredibly helpful for interpreting the liquid biopsy alongside all of the other patient characteristics, symptoms, medical history, and that is critical, actually, if this is coming into practice. We've also defined levels of diagnostic certainty, i.e. clearly diagnostic based on molecular profile, consistent with based on molecular profile, possibly consistent, i.e. that profile could be seen in a different cancer or not consistent with cancer. And this has been, again, a development step that's been really critical if this is going to come into practice. This is busy. What you would take home from this is we presented the interim analysis at an American conference. My fellow Lauren Jones presented these data on the first 64 patients. So these data have been presented. The median age is more real world than in clinical studies, over 70. A 50-50 male-female split, mainly white patients. One of our trusts does have more ethnic diversity. We don't see it here. And probably the split between stage 4 and 3, 60-40. I think in terms of the results we found, the take-home from this busy flowchart is that 80% of patients going with a scan highly suspicious of pancreatic or biliary tract cancer, so that's 8 out of 10 patients, had a positive liquid biopsy. As diagnostic tests go, for me, that's a really important finding. Now there's some nuance around how many were diagnostic, consistent, or possibly, and how that would factor in to the patient decision-making. This is busy, so I'll probably skip over it, but the point was to make was that actually we're often getting the liquid biopsy result before the invasive diagnostic result, particularly in the pancreatic cohort, more patients to be recruited on the biliary tract side. The fewer biliary tract patients because that just reflects the incidence of the cancer. In terms of ctDNA detection in suspected biliary tract cancer, that was high, 87%. And no detection around 13%. In terms of the assay performance, actually, it's going to be positive, true positive 85% of the time and false negative 15% of the time. So we don't say that that's it. The patient needs to persist with a tissue biopsy if there's a high level of suspicion. In terms of, just to give this bring it to the patient perspective, I just wanted to show you 3 cases, just checking on time. Protracted diagnosis. This is a problem, particularly with high cholangiocarcinoma. This particular patient had a diagnostic delay over 5 months with 5 attempted invasive tests. With the program just open, she came into the program, we took a blood test. Within 18 days, we had a result that was positive. The molecular tumor board confirmed it was consistent with the diagnosis, and she managed to access treatment. She's doing well, actually. The second case demonstrates precision therapy and diagnosis. 87-year-old patient with a likely intrahepatic cholangio. He was told, you're probably going to need chemo if we're going to go through the biopsy. He said, I don't want that. Actually, the program came live. He was enrolled in the program, positive tumor liquid biopsy. Actually, he's in an MSI high group. We now have immunotherapy treatment, non-chemotherapy for that. So that changed his pathway, and actually he did go on to treatment. So that was really important, and I think, again, addresses any age-related decision-making. And another patient, 89, who, again, didn't want to go through a biopsy, but she was well, had a liquid biopsy result within 9 days, positive diagnosis. She was BRCA mutant at a level that suggests this is inherited within her family. So while she didn't want treatment, her family were offered genetic screening, and that was really important in terms of their potential cancer risk. So where are we today? We've recruited 201 of the planned 228 patients, so we're nearly there. On average, we're recruiting about somewhere between 5 to 15 patients suitable for the program per month. And I hope really to be standing here next year, showing the final results of the program. This didn't happen in a vacuum. It took an entire multidisciplinary team to shift how we do diagnosis, really heralded and led by our patient voice, critical from the beginning, from the grant application to really a program being successfully run, bringing our molecular tumor board right into diagnostics, and our gastroenterologists are completely sold. Where do I see this going? If we can demonstrate what we need to, we have this flourishing, I think, genomic environment within the UK with our genomic medicine service and the commissioned genomic laboratory hubs, which are geographically distributed and aim to provide equity of genomic access across tumours. Recently, we've established a network of excellence in liquid biomarkers, and this is the route that I see this project and other liquid biopsy projects would go through. We have the first liquid biopsy laboratory in the UK, which is in the North Thames GLH, and that's a technology transfer agreement from Guardant Health, and that is actually being used in the lung ctDNA transformation project, which is probably the exemplar for that in the country right now. So with that, thank you for your attention.